Now, what you need to do is get them to wait and move when you want them to. If you say, I want you to move your arm upwards, they'll start up before you know it, okay? Because you want them to tell you about pain as well. So, I want you to move your arm forwards. When I tell you, I want you to stop if you feel any pain and show me where the pain is. Point with one finger on the other hand when you have some pain. Okay, go. And down. There's no pain there? No. Okay. Now, I want you to do it with both hands. What I'm going to be looking at now is scapular dyskinesias. See what the movement of the scapula are like. Go. Both hands up high. And down. Okay, let's just turn him this way. Let's try, just turn back that way, like that. Now, let's just try that again. And down. Okay. Now what he's got a little bit of type 1 on this side, okay, because you've got the type 1 dyskinesis, where you've got the shoulder shrugging to initiate movement. He's got a little bit of early release of his inferior angle on the recovery movement coming down. If the scapula is going to be involved in and you're finding some of these issues in elevation, what you want to do, especially if there's a restriction of movement, you would like to facilitate upward rotation of the scapula to see if that makes any difference to either pain or the range of motion. Now to do that, you can put your hand here and just cup the inferior angle of the scapula, facilitate it with your upper hand on the spine of the scapula, and you're going to try and facilitate upward rotation. This works better in flexion than abduction because you have to get out of the way of the arm in abduction. And often flexion is a good movement to assess the shoulder with. You need to do all the movements, of course, but often it works well with flexion. I want you to take this arm up. And I'm going to help you move this shoulder blade up and around like that. I don't want you to shrug it up, but I just want you to think about twisting it like that. Feel that? Yeah. Okay, so take your arm forwards again, right up and down. Let's just do it again and down. And you would ask the patient, did that make any difference to the pain? Or you might have told him beforehand, tell me when the pain first starts, looking for differences in range of the onset of pain. The other difference it can make is the stiffness of the shoulder. Is he getting up higher? Another important thing when you're doing active movements is that you give those 3 overpressures at the end of range. So take this arm up for me, please. That's fine, no pain. What happens if I do this? That's okay. And then you might add a little bit in towards quadrant as well. And then you might add a little bit in towards abduction. So in the one swoop, you've done all of your overpressures. Right, now I want you to hold your thumbs out like that. We're going to test abduction now. I want you to take both hands up in the air as high as you can go to your ears, please. Go. Stop if you feel any pain. Any pain? No. We've already done the overpressure. Let's have another look at the scapula. Go again. And down. And you seem to have early release on both sides, more here on this side, and there was the type 1 dyskinesis again here with the shrugging initiating the movement. Stop. Go. Now we're going to test hand behind back. That is often a test of internal rotation. I prefer to test internal rotation separately though. It's a combination movement of extension, internal rotation, adduction. However, when the hand starts going up the back, you start to get a little bit of abduction as it goes up. So I'd like you to take your thumb up the back as high as you can go. But people get confused with this, so just running your finger up there gives them the track that you'd like them to go in. Okay. Stop if you feel any pain. Tell me where the pain is. Go. Yep. How does that feel? And so we're going to measure where that is, and that's going to be about, say, T5, T6, down. And compare it to the other side, go. It's about the same, and down. Let's just try that again on this side. And we can give some slight overpressure there. While they're here, if you like, you can also test the lift-off test. I want you to take the back of your hand away from your body like this. Okay. Go. Any pain there? And down. And of course, you compare that to the other side. Stop. Go. When I'm assessing internal rotation, I'll assess it here in 90 degrees abduction. I'll tell the patient to relax, let me move you. Then I'll hold here with my right hand, and with the left hand just lower it down. At a certain stage, you start to see the scapula right on up and coming forwards up there. That is their limitation of movement. They can go further down, but it's not true internal rotation. Once it starts moving up, that's your limit. And normally, face this way, normally it will be just below the vertical, like there. That's about normal for most people. Now, a lot of people, you will have them here and they won't go any further. You can feel resistance as you go down from there. That is called GERD, glenohumeral internal rotation deficit. That's really important. It signifies a tightness of the posterior capsule of the shoulder joint, the glenohumeral joint. Okay? That then leads to a superior migration of the humeral head in elevation. So this tight posterior capsule leads to superior migration, which then causes impingement of the rotator cuff tendons and the subacromial bursa. We test external rotation for two reasons. One is to see if the limitation of external rotation could be a preemptor for adhesive capsulitis. The internal impingement is the other reason why. Impingement of this inferior part of the cup on the posterior superior labrum. So pain might indicate internal impingement, whereas stiffness or lack of external rotation is an early warning sign for adhesive capsulitis or frozen shoulder. Now we're going to do some testing of the rotator cuff tendons. Now you have to remember that these tests are not accurate, but we do them to get some sort of idea, knowing that there is a limitation of accuracy, but certainly if there's no movement at all, and the drop test is one of those tests where hold your arm up here. If they can't hold their arm up and it just flops down, that is a reasonable sign that there is a complete tear of supraspinatus. But first of all, we're going to look at the empty can test. Stand this way. So we take the arms into scaption, or scapular abduction, just 30 degrees forwards from pure abduction. And this is empty can. He's holding a can in his hands, he's emptying it out. Right? And as with all isometric tests, we say, don't let me move you. Just meet my resistance, and you start to put some power through there. Is there any pain there? And then ease it off gently. You don't want to just let go all of a sudden. And you can feel differences in power, but you're asking the patient for any pain response. Then we go to full can test. Now it's not just thumbs up, that's full can there. He's holding the can and it's full up as opposed to the empty can. But let's get some external rotation and let's have a little bit back like that. Same position of the shoulders, don't let me move you down. Any pain there? And you're comparing the two tests. When we rotate it backwards, we're putting the greater tuberosity more posteriorly, often moving supraspinatus out of the way, out of the impingement zone. Next is external rotation. So we have that elbows by the side, hands out like that. Don't let me move your hands together. And this is for infraspinatus. He's a little bit weaker on his non-dominant side here as well. However, to capture the oblique part of infraspinatus, which is often a more accurate test, we take the shoulder into flexion. As soon as you put them into flexion, they often want to take their shoulder back there. So it's important they don't rotate their trunk backwards on the old contralateral side. So keep them there. Just support this arm here, and you say, and you're going to be pushing down for external rotation rather, and don't let me push your hand down. Okay. And they will be weaker there because we're zeroing in on the oblique part of infraspinatus. Don't let me move your hand down. Was there any pain there? No. And certainly there was a lot more weakness on his non-preferred side than his dominant side. Now for subscapularis, hands out, elbows in again. Don't let me move your hands out. Any pain? You can also, there have been testing of subscapularis with the belly press, the Napoleon test, where it's all resisted internal rotation, or press down on your shoulder, keep your arm up, the bear hug. They're all variations on a theme. It was thought that possibly with greater shoulder flexion, there would be more localization to testing the subscapularis. Okay. If you find that empty can test or one of the other tendon tests, active resistant tests are positive, just don't let me move your hand down, and that gives him pain there and or weakness. If you want to assess the role of the scapula in that particular impingement, you can do, it's called the scapular retraction test. Probably should be called the scapular posterior tilt test, because that's what you do. You take the arm in the same position, you posteriorly tilt the scapula, then say, don't let me move your arm down, and you're looking for differences. Having moved the scapula and hopefully opened up the subacromial space a little bit, does that change their symptoms? So, hand over here, fingers just on the clavicle, and with the anterior part of your forearm and the hand, you're posteriorly tilting the scapula.
You push down on the spine of the scapula.
You're pulling back from the front of the scapula, and you're pushing the inferior angle anteriorly, like that.
Is that as a result of pulling down on the top, or are you using your forearm?
I'm using both. I'm pulling back and I'm pushing the forearm forwards to tilt the scapula back. And then I repeat that, let's say, empty can test, looking for a different result. For AC issues here, we've done palpation, and they've complained of pain around here, and palpation is tender over the AC joint just there, fibrous acromioclavicular joint. So, and especially if they've fallen on the point of the shoulder, bike rider goes over, falls on the point of the shoulder, they can either fracture their clavicle or do damage to the AC ligaments or disrupt the joint altogether. A reasonable test for AC is horizontal flexion, or sometimes in different countries it's called horizontal adduction. So I want you to take your arm across like that. Stop if you feel any pain. Let me know where the pain is. Go. How does that feel? And then we give a gentle overpressure, supporting the back the superior aspect of the scapula, and just an overpressure here. How does that feel? Okay. So if that was painful, and he had tenderness here, and he complained about pain in this region here, I'd be thinking that we've got an AC issue to deal with.
Ready? Yeah.
There are two classical tests for impingement, shoulder subacromial impingement. One is the near test and the other is the Hawkins Kennedy test. Neither of them are accurate, but the near test is much more inaccurate than the Hawkins Kennedy. The near test can be done in sitting or in standing and involves passive flexion of the shoulder joint. And positive test is pain reported by the patient. The Hawkins Kennedy test is again another passive test in shoulder flexion, and it's internal rotation of the shoulder in flexion. Part of the reason that's inaccurate, they're mainly designed to impinge supraspinatus, but the Hawkins Kennedy test on cadaver research that I have performed actually is more likely to impinge the rotator interval, which is the triangular piece of joint capsule between supraspinatus and subscapularis, or subscapularis or long head of biceps. If you move the arm from flexion to abduction, you're going to move the point of impingement more posteriorly to trap, more often, trap supraspinatus. So if you're after supraspinatus impingement, you're much better doing internal rotation in abduction. Now we've got a conundrum here, because this is the test for a tight posterior capsule. GERD, glenohumeral internal rotation deficit, is shown up in internal rotation in abduction. The pain associated with a gradually tightening posterior capsule is often different to an impingement sign, where there may be better movement down, but it's more of a sharper pain and gain in this region here, in the region of the deltoid insertion. So it can be a bit problematic differentiating between the pain of GERD, of stretching out a tight posterior capsule, and an impingement sign, but with experience you can pick up the more sharp, acute, more localized and more reproducible ping of an impingement sign. Okay. Normally we do passive movements after active movements in most areas of the body. What I'll tend to do is do all of that testing in standing rather than lie them down then get them back up again. But they may have a restriction of movement in elevation, for instance in flexion. So we're interested to see whether that restriction is present in passive movement to differentiate between the joint and the muscle. Is it that the muscle can't get the arm up, or is it that there's a restriction, a stiffness in the shoulder joint, perhaps adhesive capsulitis or frozen shoulder? So we're going to do a passive motion here. I prefer not to have a pillow because it often gets in the way as you bring the arm up. You need the patient close to the edge of the bed. Support the forearm. The Maitland text encourages you to stabilize the scapula. However, I sometimes will do that to get a pure glenohumeral joint, but first of all, I'm going to not stabilize the scapula so that I'm getting a more realistic portrayal involving some scapular movement as well. You just take up here, and you're looking for movement, stiffness coming up, patient's relaxing, any pain there. You can then do abduction. We've already done passive internal and external rotation, but we can do it here. Again, the patient may be more relaxed. If you want to explore internal rotation, you can use your front thigh to rest the elbow, go down, and then just stop the anterior translation of the humeral head. And you can explore the pain response there. Stop. The next test is called shoulder quadrant, and it's a technique used in the Maitland approach to assessing shoulders. And basically, it assesses the capsular stiffness and tightness of the shoulder. And for here, you do stabilize the scapula by putting your hand under here, and you take some slices. You're feeling stiffness and pain response. So tell me if you're feeling the pain. So take it back there, and go back, right, back there. Now I come up, and I take another slice. A slightly different angle. And I might come down at a different angle again. I might have 3 or 4 slices there. What you've got here is you've got a hump which goes over there. As I go over the hump, like that. In someone with some stiffness there, the hump may be up here. Remember, you compare to the other side. So you're seeing how much stiffness we've got on this hump, which is a capsular pattern of stiffness. There's at the bottom of the hump here, there's actually a little cave in here. And if we support over here, get the patient to put the hand on the shoulder, my shoulder, stabilize the scapula this way, take our hand down here, we can go in and find that cave. We're going into abduction and internal rotation here to find that cave. It won't go up. We've got to come out of the cave to then find the hump and get the external rotation, which gets the greater tuberosity out of the way to allow the elevation to occur. In internal rotation, we're pushing up. With the greater tuberosity is preventing any further elevation. So we've got to externally rotate, move the greater tuberosity out of the way of the cranium, then we can go over the hump. Now, with this particular fellow, the hump is really low down. He has no stiffness in quadrant whatsoever. But with someone with a pathology, you'll find it's up here compared to the other side, and treatment may involve stretching out this capsular pattern of stiffness. Again, it's another precursor to frozen shoulder, adhesive capsulitis. Often you can't get to that once the adhesive capsulitis is started. You're just trying to mobilize elevation and external rotation. So you can't even get to the quadrant position. Okay.
Yeah.
So the apprehension test is the patient becomes apprehensive and concerned when you take the arm into external rotation and abduction. They're concerned about an anterior-inferior dislocation occurring again, and so they really are very keen for you not to do that. They get very quite anxious about it. The relocation test is you put them in this position, then you apply an anterior-posterior force on the head of the humerus, and their apprehension can dissipate, can reduce. Okay? So the apprehension test, then the relocation test afterwards, and bring them down.